He's currently the chairman and chief of neurology at the Cooper Neurologic Institute in Camden, New Jersey. Dr. Jovin completed his medical school training in Germany and went on to train in neurology at the Hospital of Pennsylvania. From thereafter, he did his cerebrovascular endovascular fellowships as well as neuroendovascular surgery fellowships at the University of Pittsburgh Medical Center. He is well renowned for, again, his research endeavors, especially with involvement as principal investigators of some of the landmark trials in stroke therapy, such as Revascat and DAWN trials. We are excited to have him this morning to discuss endovascular therapies currently as well as future directions. Dr. Jovin, we're happy to have you. Welcome.
Clifford, thank you very much. It's an honor to be here in such distinguished company of speakers and audience. And thank you again for inviting me. I'm gonna share the screen. Can you guys see my screen okay?
Yes.
Okay, great. So these are my disclosures. And I'm going to start by kind of paying my respects to the big five. It all started there. It started actually way before, but we've been legitimized by these 5 landmark trials published in 2015. It was obviously a unique event in the development of endovascular therapy for stroke. In the space of 6 months, we had 5 randomized trials published in the New England Journal of Medicine, basically saying essentially the same thing, that thrombectomy for stroke, which at that time included patients, I would say, carefully selected, largely within a narrow time windows. Only escape went up to 8 hours, but most patients were enrolled up to 6 to 8 hours. Basically, all these trials saying that there is an overwhelming efficacy of thrombectomy for stroke. And in terms of treatment effect, it's important to note that the treatment effect of 2.6 found in terms of reducing the overall disability, so going from a higher level of disability to a lower level of disability, treatment effect is, of 2.6 is very, very uncommon to achieve in medicine, especially procedural medicine, and that applies also for functional independence, where the number needed to treat is 5. To put this into perspective, when we look at percutaneous interventions for ST elevation MI, the number needed to treat in terms of preventing death, stroke, or heart attacks compared to lytics alone is 29. So here we have a number needed to treat of 2.6 versus a number needed to treat of 29. You could argue that this treatment is 10 times more powerful than the widely accepted and implemented across the world percutaneous interventions for ST elevation MI. It's the second generation of randomized trials for thrombectomy have taken into account this concept of fast and slow progressors. Not every large vessel occlusion is the same. Collaterals determine how fast the infarct will grow after a vessel occludes in the brain. And that in turn will determine whether a patient is a good candidate for intervention even in the late time window. Initially, we focused on the probably the highest responders, the slow progressors, and those were the patients studied in the DAWN and diffuse trials, which have then extended the time window to 24 hours with a lot of strings attached, though, with a lot of restrictions with regards to imaging. And so where we are now is that the guidelines, which clearly in view of the latest developments need to be changed, the guidelines now endorse thrombectomy as level 1 evidence, both in the 0 to 6 hours and in the 6 to 24 hours with some imaging-based requirements attached. So we've come a long way. It's been 8 years since then, and now we have this treatment established as clearly a standard of care. But where are we? I made the comparison with STEMI, and I would say that compared to STEMI, we're in terms of utilization of this procedure, as powerful as it is in terms of its effect, we're lagging way behind. This is data from the MT 2020 initiative that Dilip Yavagal was kind enough to share with me. The numbers for 2023, 2022 are a bit better, but not that much better. We're currently doing about 60,000 thrombectomies in the US. In 2020, the total number of thrombectomies was about 200,000. That's only a small fraction of all large vessel occlusions of the patients who we could be treating. So we're lagging significantly behind. We're treating way less than half, less than a third of the patients that would be candidates for this treatment. So that's one of the big problems we have. And here's a bit of this is a recently published paper in Circulation, also the product of the MT initiative, outlining the countries where outlining the rate of thrombectomy according to geography. And you can see here that even the best places, Australia, US, etc., in terms of utilization, don't get to even 50% of patients with large vessel occlusion who receive mechanical thrombectomy. The other problem that we have is that our outcomes are not that great still. These are some of the recent real-world based data from registries or recently completed trials. And you can see that the good outcome rates hover around 50–55%. We define good outcomes as a ranking score of 0, 1, or 2, but most of us in the audience would not be happy, would not consider a ranking of 2 for themselves as a good outcome. So maybe that's something also that we need to redefine, what is a good outcome. But even by this definition, only about 50% of patients are independent in activities of daily living. So that's another problem that we need to address. If we go by a definition of ranking 0, 1 as a good outcome, then we're doing even poorer. One thing that we have improved dramatically is the technology around this procedure. We now routinely, as you can see here, the reperfusion rates are routinely in the high 80s, 90% ranges, and we do it much faster. We do it in 40 minutes median in general. That's kind of the expected door to reperfusion time medians across the country, across the world. And that's because of amazing technological advancements. I remember when I started doing this, which was about 20 years ago, as an attending, a stroke with a thrombectomy, it wasn't even thrombectomy at that time, was largely pharmacological treatment, but a stroke, endovascular stroke case was an all-nighter. You would go in, if you went in at midnight or 1 o'clock, you knew until the morning you would still be stuck in the case. And now we just go in, takes us half an hour in and out, and we're done with the procedure, and the patients are better for that. And those are really remarkable accomplishments. But other than that, unfortunately, we haven't made that great progress. One of the other problems, if you look at the numbers here, door to puncture times still are way above what they should be. In cardiology, again, I drew that analogy with cardiology. They typically get door to puncture times to balloon times, which basically means reperfusion times already, of 30 minutes, 60 minutes. That's the norm. We are at least an hour behind them. So that's another big problem, and it has to do. It has direct consequences on outcomes. So that's kind of where we stand right now. We've made great progress. Patients are better. They have more meaningful lives free of disability, but there's still a long way to go, both from the standpoint of the outcomes that we're achieving in the patients that we treat, but also from the standpoint of the patients that we don't treat, that we could treat a lot more patients. Again, this is sort of a large database, almost 7,000 patients in the US, showing the overall median door to puncture times, 87 minutes. If the patients are directly admitted, it's even more, way far from the actual goals, which in my opinion should be 30 minutes. And in general, patients who come directly to the hospital take a longer time. I many times wonder, what does it take so long? As you can see here, over an hour and a half for these patients to get from admission to groin puncture or wrist puncture. And this is important because the in-hospital workflow constitutes about 38% of total onset to puncture time. So any kind of savings in this area would make a big impact on the overall onset to reperfusion times. So how can we improve? Well, as I mentioned, we're not treating enough patients, and we are treating patients too late, even the ones that we treat, and we're not getting the outcomes that we should be getting. So the answer is in the systems of care. I do believe that we're reaching plateaus. We're plateauing on our ability to open up these vessels, because we're already, I think, doing a great job at it. See, sure, there's room for more improvement, but that's going to be incremental. We're going to get a lot more bang for the buck by focusing on systems of care and adjunctive therapy. So the systems of care we need to see really as a continuum from first medical contact to recovery. Not only just the arrival to the hospital or procedure time and so on and so forth. First medical contact to hospital arrival is a huge area of opportunity, probably the most fruitful if we focus our efforts in that. Then we have picked the time interval from when the patient is picked up in the field to hospital. Then the patient arrives at the hospital, and we have to contend with imaging and possibly thrombolysis as well in eligible patients. Then we do the procedure, and I think here we've made huge progress, as I mentioned. And then after reperfusion, we have to take care of the patient. Again, maybe that's an area where we haven't focused that much. And then another area where I think there's a huge potential for improvement is the recovery area. So how about the first contact to first medical contact, symptoms onset to first medical contact. As everybody knows, the problem we have is that strokes don't hurt. Patients are by themselves. Sometimes the onset is not witnessed. So what are ways to overcome the problem that patients don't call themselves or are not aware they're having a stroke, they can't, etc. So I think we will see more and more, and perhaps that will be the future, at least in patients at risk of having strokes, automatic stroke detection at home. There are already companies that are working on that. Samsung is already sort of entered the area as well. There are all sorts of approaches, whether it's helmets, wristbands, watches, both hands, or cameras that just look for asymmetry in movements and smile, etc. This is an example of a company called Can Do. It has 2 watches. They're still a bit big right now, but all the technology is getting smaller. This is a patient who had a WADA test, which is a condition that reproduces very well a stroke. And these are some EMG changes. The watch has an EMG component to it, and it detects asymmetry in movement during WADA. So these are very early approaches, very early technologies, but I do think that we're going to see a lot of development in this direction, and that hopefully will get us to treatment of many more patients. Once the patient is tended to by the emergency services, the decision is where to get them, and that decision is going to have to be made based on whether the patient has an ischemic stroke or whether the patient has a large vessel occlusion. There are now several gizmos, as I call them, devices that are not yet ready for prime time, but some are close. You can see here there's a long list of them. Some use impedance, others use TCDs, others use vibration properties, all sorts of different approaches, SSEP, EEG. But the goal here is to detect, number one, that identify the stroke, and then understand or increase the likelihood that that stroke is a large vessel occlusion stroke, so that the patient can be transferred directly to an endovascular capable center. And now this issue of where do we take the patient is one that is still hotly debated, and rightly so, because the trials, the data that we have so far is not doesn't guide us that clearly into one direction versus the other. This is another very interesting approach, a company called CD8 that detects facial asymmetries, and not only facial, but the patient can be filmed in the ambulance, and that generates right now by humans an NIH stroke scale score. We know that the NIH stroke score is very closely correlated with the likelihood of large vessel occlusion. So these kind of approaches, I think with time, this probably will be dehumanized, so to speak, just handed over to AI completely, and AI will probably generate a diagnosis and an NIH stroke scale score, and that may drive where the patient is going to be taken. Now, in terms of where the patient needs to be taken, the only randomized data we have so far, it comes from Barcelona, from the Barcelona area, where a randomized trial was conducted. I need to emphasize in patients who were more than 30 minutes away from an endovascular center. Randomizing the patients within 30 minutes was not considered to be ethical. This trial, when patients were randomized to either going to their assigned stroke center versus a thrombectomy capable center, so bypassing the local stroke center, when outcomes were looked at in the entire patient population, but also in the population of patients who had large vessel occlusions, the results were in fact neutral. There was no benefit from bypassing. There was no benefit from going to the local center. But again, this is a trial that looked at patients who were beyond 30 minutes from their a thrombectomy capable center. There are some signals that up to 60 minutes in this trial, the balance is in favor of going to an endovascular center, and then beyond 60 minutes, that's kind of the inflection point where it's better to take the patient to the local center. So we have some ideas of what to do with the patients once we have identified them in the field, but that's also a bit of a moving target because, and also subject to a lot of variability because we go by time, but in fact, there's a lot of other factors that matter, and that is how efficient a hospital itself is in moving the patient through experience of operators, peri-procedural care, etc. But we think that probably in patients who are very close to an endovascular center, 30 minutes, maybe even 60 minutes, it's probably preferred to take these patients directly to an endovascular center. And then, of course, we have the mobile stroke units, the benefit of which has been showed in this paper in the New England Journal of Medicine. Should we do this routinely? Mobile stroke units, of course, are not any type of ambulance. There's specially built ambulances that require first a regular ambulance to go to the patient. There's a screening, a rendezvous with a regular ambulance. To me, that is a problem because it does take time. I would like to see a mobile stroke unit in every ambulance. Maybe we will have technology in the future that would allow us to diagnose imaging, to diagnose blood, whether on imaging or other ways, in every ambulance. And to me, that's when it would make sense to start entertaining this concept of giving TPA in the field. Right now, to me, this is a very expensive and maybe not cost-effective approach compared to other modalities that we have if we invested the same amount of money in the pre-hospital care of patients. But it's certainly an approach that works in some regions. And in general, we're now helped more and more by AI applications. We all know about Viz.ai and Rapid and Brainomics. We get imaging data on our cell phones. That's great. It does improve workflows significantly. But I think the next sort of level of AI applications is going to be not only identifying a large vessel occlusion, telling us what the scan is, but also telling us based on real-time traffic conditions, based on real-time angiography availability, etc., real-time conditions, which is the best hospital to take the patient to. And there are, I think, in terms of patients and in terms of the issue of poor education in the population with respect to what to do in the case of a stroke, I think ChatGPT and AI is going to be very helpful. Just this morning, I asked ChatGPT. I said my husband cannot move the right side and cannot speak. What should I do? And the answers were spot on. You don't have to, maybe ideally you should talk to a doctor or a nurse, but I think that's good enough in terms of what you have to do. And I think this democratization of medical knowledge will come a long way in patients actually getting the right treatment in a timely fashion. Here I asked what to do, where the patient should be taken. My wife is having a stroke. Where is the best place EMS should take her? And the answer was spot on: hospital with a specialized stroke center or comprehensive stroke center. So that, I think, is gonna, it may seem trivial, but I think is also gonna get us more patients coming to the hospital with an acute stroke. So now the patient has arrived to the hospital. So you remember that 90 minutes, that is really pretty much a constant. And I kind of urge you all to look at your numbers at your hospital and see how far you are, especially in patients directly presenting to this number. And I do believe that right now, the biggest barrier we have in terms of drastically reducing these numbers is imaging. And I would sort of propose that no imaging, or as little imaging as possible, saves brain. The first thing we have to understand is how much time imaging takes us. What is the penalty we pay in terms of time when we do imaging? And that's something that, very interestingly, it's very hard to find in the entire literature. Any kind of imaging-based studies for acute stroke have not included the time that it takes to actually perform these imaging studies. And everybody that you ask, they're going to say, oh, at my place, a CT and a CTA and a CT perfusion take 5 minutes. And that's probably true in 10, 20% of the patients, or 30%. But if you actually make averages and you take into account those patients who don't have IV access, or are agitated, or have an allergy, or, I don't need to tell you all these situations that come up, you get to some averages that are actually very worrisome. And, again, this is old data, almost 10 years ago, 7 years ago. This is Swift Prime data. Things have improved. Prime, when you start looking at it in consecutive patients and prospectively, the time from doing a plain CT, not even going to the scanner, but starting the plain CT to successful post-processing of CT perfusion and CTA was 24 minutes. And if you do an MRI, you're set back even 16 minutes longer. So that's, let's say it's not 24 minutes. Let's say it's 15 minutes nowadays. What does that mean? What do 15 minutes actually mean? Well, we know what they mean because this was quantified based on the Hermes data set. This is a paper that showed that for every 1,000 patients, fast, but being 15 minutes faster, will get you 39 less disabled patients and 25 patients who achieve functional independence compared to 15 minutes slower. So we know that a 15-minute delay in workflow carries a loss of functional independence of 2.5%. And that is a pretty significant treatment effect, I would say. So we need to think about even those 15 minutes. What is the informational value in terms of us treating the patient better that will overcome a 2.5% less chance of functional independence? And my personal answer to that is I don't see the utility. I don't think that whatever we get out of imaging makes up for the penalty that we pay in terms of time, especially since most of the information, the most important part of the information we get from imaging is the size of the infarct. So we've been sort of brainwashed, everybody, with the concept that if we reperfuse a large core, we hurt the patient. It's not that it's futile, but it's actually detrimental. We're going to cause hemorrhages, and we're going to cause malignant syndromes and edema and all sorts of problems related to reperfusion. And well, lo and behold, we all know there's 3 large core trials. They did not go to 0 aspects of 0, but they've gone to pretty low aspect scores or pretty large infarcts. Here in Rescue Japan Limit, we're talking about baseline infarcts of 100 cc's by MRI. Select 2 and Angio aspects, a bit smaller infarcts, but basically all reach the same conclusion. Yes, taking patients with large infarcts leads to poor outcomes. Only 14% in Rescue Japan Limit. It's very interesting. It's a very nice relationship between the baseline infarct size and the percentage of ranking 0-2, the good outcome. Here are patients ranking 0-2, I think appropriately chosen as the dichotomized primary endpoint. 30% only in Rescue Japan Limit, 47% in Angio aspects, 38% in Select 2. So yes, these are bad strokes and patients don't do well. But compared to no treatment, so it is a prognostic factor, a large infarct, but it's not a treatment effect modifier. Imaging does not discern between the ones who are going to derive benefit from this procedure versus not. We do not have any kind of imaging feature right now, including size of core, that tells us which patients benefit and which patients do not benefit. And yes, symptomatic hemorrhages are larger, are higher, except for Select 2. Maybe that was based on the definition of symptomatic hemorrhages. There's no question that there is some downside, or there's some potential for complications. These patients are very sick and they have high mortality rates, but they do better when we treat them compared to when we don't treat them. And this kind of negates the benefit of imaging, in my opinion. Imaging just becomes a prognostic factor, just like age. We should be treating imaging just like age. We know that when you treat very elderly patients, their chances of a good outcome are low, but they're much better than if they don't get treated. And the same applies to large infarcts. Now, this information we don't need to get from sophisticated imaging studies. There are now applications that detect large vessel occlusion, also AI-based. They not only use the hyperdense MCA sign, they use a combination of factors that will tell you with about 90% accuracy, especially if you factor in the NIH stroke scale score, whether the patient has a large vessel occlusion or not. They're not going to tell you where the occlusion is necessarily, but they're going to tell you there's a large vessel occlusion, as I mentioned, with about 90% accuracy. This is data from Barcelona, Vall d'Hebron Hospital, and pretty much confirmed, validated by a group from Mexico City, Dr. Bonifacio, who looked at this technology, methinks, is the company. Large vessel occlusion detection sensitivity, specificity in the 90%, with a positive predictive value of 85% and negative predictive value of 96%. So we can detect large vessel occlusion even on a plain CT, maybe not as accurately completely as a CTA, but maybe good enough to just make the decisions based on that. What we can also do based on a plain CT is calculate infarct volume. And we are talking about aspect scores, but I think aspect scores in the future are going to go away because I think they served a fantastic purpose. But I think they're going to be obsolete because nowadays we're going to be able to calculate the infarct volume based on a plain CT, and that will give us, at least in the early time window, prognostic information. They're not going to necessarily tell us who benefits from this intervention or not, but since neither CT perfusion or MRI does that, why not just simplify everything and obtain the information that we need to obtain or that we think it's useful with the simplest possible tools that take the least amount of time. This is data published by Santi Ortega from University of Iowa, also with AI-based application. Methinks showing a very good correlation, very comparable to CT perfusion when we measure infarct volumes on a plain CT with the gold standard being MRI. But what I also always get is, okay, but how about a CTA? You still need to do that, right? Because if you don't have AI-based applications such as Methinks, you still need to do your CTA to confirm the large vessel occlusion. And my answer is not necessarily. We have the NIH stroke scale score. If you don't have more sophisticated technologies that sort of refine, increase the accuracy, the NIH stroke scale score is a pretty good predictor of likelihood of large vessel occlusion or not. This is the largest study that I know of that looked at this question. Over 2,000 patients with stroke who had a CTA, and the bottom line is that if you have an NIH stroke scale score of 9 or above, your positive predictive value of having a large vessel occlusion, and that was really large vessel occlusion. It was a proximal large vessel occlusion, including M2. But nowadays, we are sort of venturing in treating smaller occlusions. Whether there's benefit or not, we haven't firmly established that. But in any case, if we consider also the more distal occlusions beyond M2, this number is going to go up. So, we are already at about 80% positive predictive value with an NIH stroke scale score of 9 or greater. And the higher the NIH stroke scale score, the higher the likelihood that we're going to have a large vessel occlusion. So we can always set the thresholds as we think is acceptable for our center, our specific environment to diagnose a large vessel occlusion without doing a CTA. And while this may sound crazy, it's really what cardiologists actually do. If you ask your cardiologist at your center, you'll always get the answer that when they have an ST elevation MI, they not always have an occlusion that is treatable. In fact, about 10-15% of the times, they're going to have no occlusion. This is called MINOCA, myocardial infarction with non-obstructive coronary arteries, and it's a well-known entity that is seen in here 5 to 25%. In general, it's 10 to 15% of the times in patients with ST elevation MI. So this is something that the cardiologists have been doing forever. they can also now do CTAs, but they don't. Why? Because they know that that time that it takes to do a CTA is very precious time. So for me, this time is brain saying it has to be interpreted also in the context that yes, time is brain, but imaging is time, therefore imaging is brain. And I would say that in view of the large core trials that show that there is benefit even with large cores, and by the way, there's another 2 large core trials that still have not been reported, one of which, LASTE, in extremis LASTE, has gone from aspect 0 to 5, and that trial has about 100 patients. It was stopped after SELECT 2, and the other large core trials due to ethical considerations at the suggestion of the DSMB. But that trial has about 100 patients with an aspect score of 0 to 2 by MRI. So those are the largest of the largest. It's an early time window trial. So that will tell us if even those largest cores benefit from reperfusion or are harmed by reperfusion. But until then, I would say that, in view of the large core data that we have, it's not only that, in my personal opinion, it's not only that a CT perfusion is unnecessary. I think it's detrimental to patient care because we don't get any information from a CT perfusion that should guide our treatment. However, we are wasting time that reduces the patient's likelihood of having a good outcome. We have started to just take patients directly to angio. I do believe that this is going to be increasingly used in the future and maybe even become standard. We have noticed when we started first with patients transferred from other facilities. I still think there are centers in the US nowadays who still repeat imaging when patients arrive to the endovascular center, which is amazing to me to hear, but it happens. But in any case, when you don't do that and take the patients directly, you save about an hour in time to reperfusion, and you can make the calculation of that, what that means in terms of patient chances to have a better outcome. And of course, now we have randomized data that this approach is superior to just going the conventional way. It is a small trial, 74 versus 73 patients. This is a trial where one group of patients went directly to angio without regard of the baseline core size, aspect scores, anything. It's simply ruling out hemorrhage based on a flat panel CT that allowed the patient to also receive TPA, by the way. The other arm was the conventional route, CT and CTA. And you can see this is a stellar stroke center. Even with a conventional route, they go directly to the CT scanner. They bypass the ED. And they had a door to puncture time of 42 minutes, which is off the charts good. But even so, they saved 20-something minutes when they went directly to the angio suite. And these are the outcomes. Of note, the direct to angio suite also, the conventional arm also excluded patients with a large infarct because that is the standard, right? So patients with aspect scores of 4 or less were excluded. And as a result of the time saving, and I would say also of the fact that the patients with large infarcts were not included, we have a statistically significant difference on the ranking shift with an adjusted core, adjusted odd ratio of 2.2. This is obviously a small trial, and it needs to be replicated. And there is another a trial that aims to replicate this on its way. But these results are very promising, and quite frankly, they make sense to me. And when people say, well, how about the safety here? How about symptomatic hemorrhages? No signals of harm when we take these patients directly to angio. No signals in terms of mortality, symptomatic hemorrhage, hemicraniectomy, you name it. The only signals of harm, of course, are going to be the vascular, are going to be in terms of procedural and complications, whether neurological or peripheral. And there's a meta-analysis that I was part of in terms of publication. We looked at all studies that examine the benefit of going directly to angio. If you look here in terms of, there's a handful of studies that have looked at going directly to angio versus not. These are, of course, none of them are like AngioCat, the randomized trial that I showed you. They're all sort of case series, but the signals are clearly in favor of going directly to angio. Ranking score 0.2 in favor of angio. Door to reperfusion time, of course, makes a lot of sense in favor of going directly to angio. These are, I think, important findings that need to be confirmed by prospective trials. But if they are confirmed, I don't see, especially in the light of the positive large core trials, why we should not be going directly to angio. Another benefit of going directly to angio, in my opinion, there's a lot of talk about whether we should be doing CT perfusion to detect these small vessel medial or small vessel occlusions. The data that we have, I think, indicate that the NIH stroke scale score so far is the biggest driver of benefit. So if the patients have an NIH stroke scale score that is high enough, and by the way, all of these trials that looked at going directly to angio didn't take all patients, didn't take any patient with an NIH of 2 or 0 or whatever. The AngioCat trial that I showed you, the randomized trial, specifically took patients with a high likelihood of a large vessel occlusion, NIH 10 or above, and early presenting patients. Why? Because in the early time window, you have a lot of fast progressors, and those are most sensitive to delays. So it does make sense to use this direct to angio approach only in patients who are most likely to benefit, the ones who are most likely to have a large vessel occlusion, and populations enriched with respect to the incidence of large vessel occlusion and with respect, with the incidence of fast progressors. So with medium vessel occlusion, same thing. Patients have a severe enough deficit, and again, that can be fine-tuned depending on the place's infrastructure, manpower, day of the night or day or whatever. But you go directly to angio, and that's the best way to find a medium vessel occlusion and treat it on the spot. This is kind of a small movie that Mark Rebo graciously allowed me to use from his center. This is a 5-minute direct to angio workflow movie. This is what happens when a patient gets to their center. It all goes over 5 minutes, and that includes a flat panel CT, which will then allow the detection of hemorrhage if it's present. And if it's not present, the patient can and should be still treated with lytics, in my opinion, even before going for endarterectomy, for thrombectomy. But you can see, you can very nicely see detect intracerebral hemorrhage with the current flat panel technology. And that is relevant because we finally, I'm very excited about this development. We finally have data that we can actually help patients with intracerebral hemorrhages, with primary intracerebral hemorrhages, with minimally invasive evacuation techniques. And so you could argue this is the ENRICH trial recently presented at INSOC and AANS. Minimally invasive evacuation, you can do it in the Angio suite. And there is some data suggesting that the earlier you do it, the higher the chance of a good outcome. So the paradigm could be such as what we have at our hospital. We have a navigation system in the Angio suite. If the patient has an intracerebral hemorrhage that is diagnosed based on the direct to angio paradigm very early, one consideration is to treat it right there. Again, these are things that we need to refine in the future, but I think that's something that at least should be investigated as a beneficial feature for patients in the future. Now, how about beyond 6 hours? Well, beyond 6 hours, we're dealing with a lot of, if you are still beyond 6 hours and don't have a giant infarct, you're a slow or a medium velocity progressor. So there, things are a bit different because the penalty that we pay for delaying our thrombectomy are not as severe as in the early time window when we're dealing with an enriched patient population of fast progressors. We know that there is benefit, and this is a meta-analysis of all patients who were randomized up to that point. In the meantime, there's more, but this was published in 2021. And there are a few important considerations, important results. One is that the treatment effect does not seem to be diminishing based on the time window. If you select patients based on a small infarct, essentially, whether you treat the patient in the 6 to 24 versus 12 to 24 hour, you derive benefit. But it seems like that you derive more benefit in the extended time window than in the early time window. And also important, these were signals that we perhaps ignored, but aspect 07, of which there were very few in this meta-analysis, relatively few, I should say, versus aspects 8, 10, no difference in treatment effect. And also very important, most of these patients were part of DAWN and DIFFUSE 3. So there's no surprise there. There was strong treatment effect when these cases were put together. But even the other patients who were not necessarily and certainly not selected based on computer-derived measurements of core size, and many of these patients were just selected based on a plain an aspect score on a plain CT. There were trends, there were signals of benefit even in these patients who were selected not based on advanced imaging. And the confirmation that is true, that selecting patients based on plain CT, even in the beyond 6 hours, comes from the CLEAR trial published in JAMA Neurology 2021. This is a registry, it's not a randomized trial. But it does show that when patients are selected based on CT alone versus CTP versus MRI, there are no even direct trends towards better outcomes in patients selected based on advanced imaging. And a CT scan with an aspect score is good enough. And that makes perfect sense because given the huge treatment effects that we've seen in the beyond 6 hour patients when selected based on CTP and MRI, it would have been very surprising to find that patients selected based on CT derived no benefit. Another nail in the coffin, so to speak, to selection based on advanced imaging comes from Mr. Clean Late. This trial selected patients who were not eligible for diffuse 3 or DAWN, who presented up to 24 hours, 6 to 24 hours, and were selected based on aspect scores and presence of collaterals on CTA, so no advanced imaging. And this is a state-of-the-art randomized prospective trial that was in fact positive with an adjusted common odds ratio of 1.67, which is comparable with some of the 2015 trials. So very strong, very robust treatment effect, again, suggesting that we don't need advanced imaging. We don't pay such a steep penalty, but it's not clear at all that advanced imaging is necessary for selection of patients. This is a study that I was involved in from the UK. In the UK, it turns out patients are not treated outside of regular hours, at least at certain centers. So if you come in after 6 o'clock in the afternoon, up to 8 a.m. or 7 a.m. or whatnot, you don't get any thrombectomy because the NHS does not cover this treatment. So that afforded, it's a sad situation, but it afforded an opportunity for a close to randomized trial, if you want, a comparison of patients treated versus non-treated beyond 6 hours. These patients were selected as they do at that center solely based on an aspect score, which was prospectively recorded in all patients versus whether treated or not treated. Patients who came out of hours were not treated. The ones who came during regular hours were treated. You can see here, there's a double in mortality, more than double in mortality, patients presenting beyond 6 hours of symptoms onset with aspect scores of 6 or greater, which was considered to be the criteria for treatment, and very strong treatment effects in favor of treatment. Again, these are all patients who are selected just based on a plain aspect score, no advanced imaging. And the latest piece of support in favor of a treatment based on without advanced imaging in the extended time window is the Tesla trial, which was a trial where selection was only based on an aspect score. This study did not make the primary outcome. It was not positive based on the primary outcome, but there are very strong trends of benefit. This is a subgroup analysis. This study was just presented at ESOC. Again, it is not a positive trial, but it has very strong signals of benefit in patients selected just based on a plain CT. My guess is that when we put all these cases together in an individual level meta-analysis, which I'm sure will happen, it will pan out that patients, I'd be very surprised if there would be any lack of benefit in patients selected based on a plain CT only. I'm going to switch now, talking about the rate of outcomes that are not as what we expect. One way to improve these outcomes is to enhance the effect of thrombectomy with neuroprotection. And neuroprotection has been a big problem in the past. It has been sort of the graveyard of stroke trials. Hundreds of trials have been performed in humans, and none of them has been positive. So why should we start doing it again? And the the answer is there's several weaknesses of these trials, including animal models, etc. But the biggest problem with neuroprotection in the past was that neuroprotection was being studied in very controlled models of MCA occlusion, reversible or irreversible, and then carried out in humans, in patients, without regard to the vessel status, whether occluded or not, the size of the vessel, location, etc. So that has introduced huge confounding factors, and the advent of the reversible model of MCA occlusion in humans, which is thrombectomy, made us reconsider this issue of reperfusion. The NIH has recognized this limitation, including some other limitations with regards to animal studies, and has created this very sophisticated network of basic research that studying neuroprotection in the context of ischemia reperfusion. The first batch of compounds that were, or approaches that were tested as part of the SPAN network were these 6 compounds, 6 pharmacological compounds and remote ischemic conditioning. These approaches were tested under very rigorous protocols, double-blinded, completely blinded at 6 independent labs across the country, using behavioral outcomes, very, very rigorous assessment paradigms, and you had to fulfill certain criteria to be able to go to the next phase, and you had to go through several phases of testing to be deemed positive and make it, so to speak, to the human, be considered for human trials. And out of these 6 approaches, there has been only one, which is uric acid. Uric acid is a antioxidant with improvement in microcirculatory abilities. There has been a phase 2 trial that was strong trends of benefit, didn't make it on the primary outcome, but this was a reperfusion intravenous versus endovascular. Most of the patients enrolled were intravenous TPA, with some endovascular patients as well. With subgroup analysis, they were all positive in pre-specified groups, such as women who have low levels of uric acid or patients with diabetes. What I wanted to highlight here is in the subgroup of patients who underwent thrombectomy in this trial, which were just a handful, 45 patients, very strong signals of benefit, sort of mirroring, if you want, the SPAN results in favor of patients treated with uric acid. So that's one trial that we're hopefully going to see in the future. There have been a lot others. They're too numerous to mention all of them. The most studied and the best known is Escape NA1. Nerinetide is a anti-excitotoxicity drug that was studied in the Escape NA1 trial. This trial enrolled 1,100 patients. It was a negative trial overall, but it turns out that TPA inactivates nerinetide. So patients who were treated with TPA did de facto not have therapeutic doses of nerinetide. When they looked at the subgroup of patients who did not receive TPA, there was a very strong difference, a very clear, statistically significant difference in favor of nerinetide, paralleled by infarct volume reduction, etc. And that sort of made the investigators go to the next step, which is Escape Next trial. This is a trial that only enrolled patients who were not treated with TPA. This trial has finished enrollment. It's going to be very exciting to see. I hope it's going to be the first trial that will show benefit of neuroprotection in conjunction with thrombectomy, but we don't know what the results are. But stay tuned. Probably in the next couple of months, we will know. This is an anti-inflammatory drug working on the TLR4 receptor, which is a receptor involved in the inflammatory pathway of ischemic damage, and has been recently shown in this publication. This was actually published, I think, a month or two ago in JAMA Neurology. Very significant trends of benefit, more than trends, statistically significant reduction in mortality and improvement in or reduction in disability. Again, this was a phase 2 trial. We need confirmation from a larger trial, but this is also a sort of a promising approach. This is a trial that was just published in JAMA Neurology. Butyl phthalate trial coming out of China. It's a phase 3 trial that is positive, but I think it needs confirmation in the US population. So I'm sure we're going to see more trials involving this drug. This is a very interesting approach that involves neuromodulation. Transcranial stimulation in the setting of an acute stroke. It's published in the last issue of JAMA Open. It is, I think, something that will open up the venues for modulation-based trials in acute stroke or subacute stroke. This is a patient who was treated with this approach, an M2 occlusion, not considered to be amenable to thrombectomy. And you can see here that following treatment, there is improvement in perfusion. This is something that is very early and very just a handful of patients, but it's a really intriguing and I think an intriguing approach that deserves further evaluation. This is an approach, a drug that is a pegylated carboxyhemoglobin. It carries more oxygen to the tissue. Its main effect is dilating leptomeningeal anastomosis. So it's a collateral enhancing drug. It has just finished a phase 1 trial with interesting results, but again, very small number of patients. However, this type of compound is something that I think makes a lot of sense to give in the very early stages of stroke, because it is a drug that increases collateral supply to the tissue and thus has the potential, I would say, the holy grail of neuroprotection in the field, to transform fast progressors into slow progressors through enhancing collaterals. And we know it is possible from the FAST-MAG trial and from the trial involving nerinetide in acute stroke, which is currently a separate trial currently going on in Canada, that you can give neuroprotectants in the field within the first hour after stroke, the golden hour, so to speak. It's been shown to be possible. We have to see, based on the nerinetide trial, whether it's called Frontiers, whether it's the right drug. I'm convinced it's the right approach, and I hope we'll soon find also the right drug for this kind of approach, giving the drug in the first hour as soon as possible at the patient's home, in the ambulance, etc., so that we freeze the progression of the ischemic stroke. So moving on to thrombolysis in conjunction with endovascular therapy, I think there's very little doubt that for patients who are considered for endovascular therapy, TNK is a better drug than TPA. At my center, we have switched to TNK in general for all patients with ischemic stroke. In lieu of TNK, it has several advantages. But since this is a talk focused only on endovascular therapy, I think for endovascular patients, there's data data is pretty strong that we should be using TNK before thrombectomy. But that brings us to the question: should we use anything? And last November at the WSC, the World Stroke Organization meeting, there was an individual level meta-analysis on 6 trials aiming to answer this question: should we give thrombolysis before thrombectomy? This meta-analysis was powered to show non-inferiority at the margin of 5%, and this was not possible. It was not possible to show non-inferiority. It fell short of that. But if you look at the point estimates in terms of giving thrombolysis before thrombectomy versus not, the numbers are very close. And so basically the big value to me has been the subgroup analysis, where there is a very clear trend of showing that the earlier you give thrombolysis, the earlier the patient is with respect to time from symptoms onset, the more beneficial administering thrombolysis prior to thrombectomy is. Here you see 3 tertiles. The third tertiles patients presented latest, the point estimates were in fact in favor of thrombectomy. So, and then there were other subpopulations where I thought it would make sense to not administer tandem carotid lesions, for instance, where you may need to give dual antiplatelet therapy and you're concerned because patients have thrombolytics on board. But this didn't actually pan out to be a clear differentiator. Same with low aspect score patients. One would have thought that the large infarcts would do better treated directly with thrombectomy, but that did not pan out based on this individual patient meta-analysis. The conclusion of the investigators was there's no proven benefit of intravenous TPA prior to endovascular therapy for eligible patient. And if there's a benefit, it's likely to be small, with a number needed to harm of 57 for each additional case reaching functional independence. In the worst case scenario, there would be a risk difference of 7%. So in the best case scenario, giving IV TPA or TNK, well, this was actually a TPA trial, so we don't know about TNK. Giving IV TPA would result in a 7% improvement in outcomes, but that's the best case scenario. So my take is that based on these data, I use IV lytics. TNK is what we use at my center at Cooper University Healthcare. We use IV lytics as default before endovascular therapy within the 4.5-hour time window. Unless there is a good reason to withhold, I still tend to have a high threshold for tandem occlusions. made low aspects, especially the really low aspects, less than 5, and patients who are known to have a risk for intracerebral hemorrhage, because in this meta-analysis, intracerebral hemorrhage was found to be, symptomatic hemorrhage was found to be more frequent in patients treated with TPA. And finally, in places where cost is a consideration, that's something that is also very important. There's countries where patients pay out of pocket, and this small additional benefit may not be worth it. And then, of course, in the extended time window, that's something that I'm more and more inclined to. The further out the patient is, the less I'm inclined to administer thrombolysis prior to thrombectomy. And in fact, at ESOC, I don't have the presentation, I don't have the slides, it's very new data, but it has been shown also based on this plethora, this large database of patients, 6 trials, individual level meta-analysis, that up to 2 hours and 15 minutes, there is benefit of giving intravenous TPA to patients undergoing thrombectomy. And beyond this time point, there is no indication that TPA does much in terms of benefit. So that again confirms the fact that this approach works best when given very early. Certainly in the 3 to 4.5 time window, it's not very clear that TPA is of any benefit under these circumstances. And probably the reason why this benefit is there very early is because of microcirculation. It's less clear to me that TPA or TNK improve the ultimate recanalization results. And therefore, although there are small differences, but these differences are unlikely to make up for the difference in clinical outcomes. So one, I think, very attractive hypothesis is that the benefit of TPA prior to endovascular therapy, or TNK for that matter, reflects its effect on the microcirculation, which many times we can't assess. And the benefit of agents that work on microcirculation was nicely highlighted in this small trial, 100 and something patients, called CHOICE. It was randomized. Patients received either placebo or TPA intraarterially after thrombectomy, including in patients with pristine TK3 reperfusion results. And this trial did show that there is a significant difference in favor of administering intraarterial alteplase after thrombectomy. Again, small trial, we need confirmation, but is again another argument in favor of focusing also on microcirculation in these patients. Very briefly, a few thoughts about basilar occlusion. I haven't spoken about it. Until recently, we had no evidence of benefit as strong as the benefit was in the anterior circulation. We had no evidence of benefit in the posterior circulation. This has changed in October of last year with the publication of 2 trials, Attention and Bao-Chu. Bao-Chu, I had the privilege to be one of the principal investigators. And there were 2 other randomized trials that were negative that were published before that. The total in an individual level meta-analysis, total number of patients, about 1,988. Both Attention and Bao-Chu were positive with very similar results. The difference between them was Bao-Chu went to 6 to 24 hours, Attention 0 to 12 hours. These were the main differences between these 2 trials. And putting all these patients together showed a treatment effect that is very similar to what we've seen in the anterior circulation, a treatment benefit of 15.5%. involving all these patients, and very strong, very significant differences on secondary outcomes as well, including ranking 0.3 differences at 90 days, ranking 0.2 differences, and also very, very important, despite a clear difference in symptomatic intracerebral hemorrhage in the endovascular group, 10-fold increase in hemorrhage rates. There is in these patients, there is a significant mortality benefit. So basilar occlusion, as we all knew and suspected from our own experience, that this actually shows, brings proof in the form of randomized data that thrombectomy for basilar occlusion reduces mortality. And in subgroup analysis in these patients, patients who had atrial fibrillation that were underrepresented in bowel and attention because of a high prevalence of atherosclerotic disease in these patient populations from China. But when putting these cases together, there is benefit even in patients with atrial fibrillation, but there's still uncertainty with regards to benefit in patients presenting with NIH stroke scale score less than 10, and this is an area that requires further study and further trials in the future in basilar occlusions. Finally, I just want to say that I showed the chain of the spectrum of interventions that we need to focus on. That includes recovery. There are now applications such as Nora Health from Spain that shepherd patients and help with their integration into the health in their normal life, re-entry into the normal life or reintegration in society after the stroke, which has been shown to have beneficial effects on outcomes, readmission rates, things like that. That's something that we're going to be seeing in the future. Finally, there are interventional approaches for recovery. I showed you neuromodulation in the acute stroke setting. This is now in the recovery setting, VNS, vagal nerve stimulation, for improvement of motor function in chronic stroke is something that is proven to be beneficial, and it's actually FDA approved and in starting to be used in the US. That's a very exciting approach. And then finally, I think part of the future in terms of endovascular treatment will be brain-computer interface applications. This is a brain-computer interface application obtained through surgical implantation, open surgical implantation, but I can see a future for brain-computer interface with endovascular approaches. This is a patient whose speech was decoded with the help of a brain-computer interface setup. This was a young man who had lost his ability to speak because of anarthria due to a brainstem injury. And so I just want to end in this note. I think we have made a lot of progress. The future in terms of endovascular therapy, I think, is wide open, very promising. And we shouldn't see it only in terms of opening up blocked vessels in stroke, but along a much wider spectrum. And thank you very much.
Thank you, Dr. Jovin. That was an excellent talk with regards to where we are and what the future holds for endovascular treatment from all aspects of the systems of care, from, again, from the patient being at home all the way to recovery. And so we definitely learned a lot. I'm going to open up the floor to questions.
Yeah, I just want to say, Tudor, that was great. You covered a lot. I want to sort of recognize, I've known you for a long time, and you've been pretty singular in your vision for stroke and pushing the care forward, and an early and strong advocate for the the more expeditious approach of going directly to angio suites. And I have to say that I was more of a skeptic of that approach, and you're winning me over. Especially with as you so rightly point out, I would say surprising impact on the large core strokes, where we're seeing really striking benefit to endovascular therapy, and in the late time windows and the large core. It really does make a compelling argument for more aggressive, more rapid approach going to the angio suite and foregoing a lot of the sophisticated CT perfusion and other studies.
Yeah, and thank you. And winning you over, Cameron, means a lot to me. To be honest, it does. I think that a lot of the questions now may just be focused on the cost efficiency, the economics of these approaches. But there are actually cost effectiveness analyses done based on the AngioCat trial in Europe that are detailed exactly, what the cost savings are versus of a conventional versus direct to angio approach. I think if we look at our cardiology colleagues who have 5 angio suites in every hospital and manpower that is orders of magnitude higher than ours, I think that and given the fact that, again, arguably you can say that thrombectomy for stroke is certainly more powerful treatment effects, the approach should not be we can't afford it because we don't have the resources at our hospitals. We should be demanding these resources because they are justified. But there are a lot of challenges on this side. We all face this issue of having to add people to our groups of interventionalists just to cover, because the need is on the emergent side of the procedures. So that's something that where there's a big difference compared to our cardiology colleagues who can live off elective procedures. So I think for us to take it to the next level, I think in neuroendovascular we need to have more elective procedures that would give us sort of the infrastructure to cover call and to treat more patients acutely. But I also want to point out that if you fine-tune your inclusion criteria to have maybe 80% or 85% or whatnot likelihood of a large vessel occlusion that you're going to treat, you're only going to need manpower for 15% more patients, because the other ones you're going to treat anyway, especially now with these large cores, right? The patient in whom you delay the workflow because you're doing imaging and so on and so forth, and then you say, oh no, the core is too large now, I'm not going to intervene. That's passé. We're still going to treat these patients. So in fact, all we're going to do is we're going to treat maybe 15% more patients, take to angio 15% more patients. And that's what cardiologists do. And I think if you do the economics from that standpoint, you're going to come out ahead.
Yeah, I think that really is the big shift, because in the past there were a lot of people we assessed and declined to treat who now are candidates that we really can't turn away. So that really is the shift, that there's just not that many patients that we don't treat. And also, as we've done more and more of this, we see that the harm, the treatment is just very safe, and the reperfusion hemorrhages and things are just not the issue that we all feared.
Yeah.
So that was something early on. I was really surprised to see that we were opening up these vessels and just not seeing the hemorrhages. And And that, and now the large core, it just gets harder and harder to find a reason not to treat somebody.
Yeah, and I think that the detrimental effects of reperfusion, if you believe in those in this concept, are going to be mitigated by neuroprotection. I think there's going to be a big role. The Aptol trial that I mentioned, these anti-inflammatory drugs, they do seem to have some protective effect in terms of reducing the risks of hemorrhages. And so, if we combine these, reperfusion with neuroprotection, probably the biggest, it's just a guess, that the biggest effect is going to be felt on these large core patients.
All right. Well, we're hitting our time window, and I really appreciate you being with us this morning. It was a great talk, and as always, you've had better vision into the future than most of us. So it's really helpful to learn from you, and thanks again for being with us.
Thank you. Thank you for having me, Cameron.
Bye-bye now.
Thank you again, Dr. Jovin. Bye-bye.